Well, I am John Waits. I am a family physician that has lived and worked in Bibb County, Alabama, for the past 14 years. I am the program director of the Cahaba Family Medicine Residency. Um, we are a 444 family medicine residency that you guys have been interacting with, I guess, for the three previous sessions. We started in 2013. I'm also the CEO of Cahaba Medical Care. Our headquarters is here in Centerville, and we have several sites. You know, when we talk about evidence-based medicine and we talk about impact, evidence-based medicine principles tell us to start with mortality. That never lies, so to speak. And so, let's think about what infant mortality is, and it's the death of an infant before 1 year of age. These are deaths per 1,000. As a family physician, if you don't have a public health degree or are not in academic OBGYN, you may not have thought very deeply about this statistic, but it's incredibly powerful and incredibly problematic in a lot of ways that I'll get to. The infant mortality doesn't lie, but it also is super insensitive. Many other countries' infant mortality rate are what does a public health department consider a live birth? And sometimes the lay public or even the medical community thinks of infant mortality as only obstetrics issues, but it may not be obvious if a 4-month-old dies in an unrestrained, car accident, at 4 months. That's part of infant mortality. SIDS is part of infant mortality. So it's not only obstetrics that goes on here. That being said, it's mortality, so it's not a subjective number. So it is a well-known fact that infant mortality, it's more than just a definition. It's more than statistics. It is a well-known harbinger of state failure at its worst. And it really is, women and children are kind of the foundation of society, and really the linchpin of the healthcare system. It's often moms that are presenting to care decades before the men are coming in. It's often moms taking kids to the doctor. It's often mom is the primary health care giver during the 360 days of the year that they're not seeing us for 7 minutes in a visit. So infant mortality rates these numbers don't lie in terms of what they portend for the way a healthcare system takes care of women and children. It's an intractable problem, and just to give you some Alabama-specific data, the U.S. infant mortality rate is at its best ever at 5.8. So that's, remember our denominator, that's 5.8 infant deaths out of every 1,000 live births. It's interesting. 2020 goal was an infant mortality rate of 4.5. And a decade later, when they rewrote the Healthy People 2020 goal, we were so far from 4.5 that they revised our goals for the country to 6.0. And, with some fanfare, several months back, the most recent data from 2014 is that we actually hit that goal. Alabama's infant mortality rate is 9.1. Let's put this into context, though. The United States, now this graphic came a year before. This is 2013 data. So we're 5.8 now, 6.1. Let's put this into context of other developed countries. You know, you can see Finland with an infant mortality rate of 2.3, Japan at 2.3. So right now, the CIA World Factbook puts us at 170 behind Bosnia and Serbia. So if we're measuring how we take care of the whole population at a non-subjective infant mortality rate, we're 170 in the world. This doesn't tell us everything about the U.S. healthcare system, of course. I know this is a very polarized issue this past decade, using statistics like this, but it is something that has to be thought through, no matter what your political stripe or no matter what your proposed solutions are. The care of women and children needs to be thought through. In the Alabama context, continuing on the theme of this is an intractable problem, we've been about this infant mortality rate for about the last decade. A precipitous decline in the post World War II era, but we just can't get anywhere near the U.S. rates. But here's something that's interesting. Also, currently in the news is these healthcare disparities. So if you look at the red graph, that is our African American population in the state of Alabama over the last decade, and the blue plot graph is the white population. And so really the white population in the state of Alabama is consistent with the U.S. Infant mortality rate. Still, 2 to 4 percentage points off other developed countries. But if we were to design policy or think clinically about where something's going on at the public health, community health, primary care level with our African American population. United States, 2015, 23,000 infants died. Let's be not only public health, community health, but let's be family doctors. What is going on? Why are kids dying from birth to 1 year old? Well, birth defects is a key dynamic, and most of these are a little bit out of our scope. We need to do a good ultrasound, early detection if we're doing our own ultrasounds, but for the most part, that's the pediatric surgeon or folate deficiency. There are things we can impact there. The biggest ones: preterm birth, low birth weight, in terms of contraceptive counseling, contraceptive access, spacing births 18 to 20 months, early detection of high-risk situations. Injuries and sudden infant death syndrome is bread and butter family medicine, primary care, doing a good job at the well child check, having a system in place for home visits, support for new moms. And then maternal pregnancy complications is the other leading cause of infant death. So this definitely is an obstetrical issue that relates to the access issues that we're going to get to. Relatively overlooked risk factors in the literature. Really, this access issue is so intractable that it's often off the radar screen of the ACOG practice bulletins, the CDC documents. Uninsurance shouldn't be intractable, but it is in ways that are difficult to articulate, but we'll take a stab at it. Story. I was a medical student at the University of Alabama and had the pleasure of being a faculty member there for about 8 to 9 years in the family medicine and in the OBGYN department. Pickens County is the county there on the west side of the state, the left-hand side of the state. In 1987, 88, there was a malpractice crisis in the state. There was a 9-month period of time in the state of Alabama that there was not a liability insurance carrier that would offer a malpractice policy in the state of Alabama. And during that time, we had significant tort reform at the legislative level. There is a physician-owned malpractice insurance company now that came into being that is one of the national leaders. But for a 9-month period of time, nobody could write an insurance policy for most physicians, and tons of labor and deliveries closed in the late 80s. mostly in rural areas, these smaller hospitals that could not, self-insure with a big university policy or what have you. Pickens County was one of those. But Pickens County, unlike every other rural hospital in the state, had 2 family docs who did an OB fellowship in Tuscaloosa, Alabama, and decided we're going to go back to our hometown and reopen labor and delivery. They did that in 1992. And one of my colleagues, Dr. Jim Leeper at the University of Alabama, studied the subsequent decade. He used 2 control counties in Clark and Monroe County that had uninterrupted care, and 2 other control counties that did not have labor and delivery. And what he found was a statistically significant difference in the infant mortality rates in the counties that had labor and delivery compared to not, and then statistically significant infant mortality rates from the 5-year period where Pickens County did not have a labor and delivery. And by opening their labor and delivery, their infant mortality rate dropped to about 6, which was consistent with these rural counties that had a labor and delivery open. In fact, there was 1 year where the infant mortality rate was 0. The N is small, don't get overwhelmed by the 0, but this study was presented to me as a 3rd-year medical student in a family medicine interest group meeting. And honestly, it's the seed of why I went into family medicine obstetrics. This so captivated my imagination that it was very formative for me. Local prenatal care, local obstetrics is critically important. Rural access to peripartum care is decreasing. So this slide right here, the Zoom share screen, I think it says 1980 at the top. I can't see my header because of the share screen. But pink means good. The pink counties on the right have labor and deliveries open. Dark red is labor and delivery is closed. Ignore the urban counties, okay? And watch what happens. I'm going to scroll through this screen. I want you to get a colorful visual image of 1980. I think it goes 85, 90, 95, 2000 at the labor and deliveries that closed in Alabama. And so this is where we are. And so this is where we are essentially today. And most states in the country have maps that are. And the issue is, if you read public health, they say, well, just invest in a good ambulance. Just let's do prenatal care. Well, the dilemma is the same thing happens with prenatal care. So here is the same story. Yellow is good, brown is bad. When labor and deliveries close, prenatal care falls away. Sometimes you have guys going out for a few half days a week, but the institutional knowledge in the ER of how to take care of a pregnant woman leaves. So decreased access to peripartum prenatal services means increased travel time for pregnant women. In the article that you read, you saw that travel time relates to length of stay, complications. So here is some geocoding that we did. This is Alabama in the 1980s. The blue H sign is obviously the hospitals, and you got 10 minutes, 20 minutes, 30 minutes travel time. So in this map, green is bad. Green is well over 30 minutes. This is assuming you're one of the 80% of rural population that has access to a vehicle, meaning, you can at any moment have a car. Your husband doesn't have the only car and he uses it for work, or maybe you don't have a car at all. So watch what happens when labor and deliveries close in the state. This is 2011. It's a significant difference for 50% of the state. So access is an issue, and it relates not just to delivery, but it relates to prenatal care, and it relates to transportation. Even if you have reliable transportation, well, now it's harder. Gas is expensive. Any of you working in rural, in the interest of time, I won't belabor, but you can all think about just getting your adult non-pregnant patients to specialists in the city. So final slide. I know I'm running out of time, but can tell you story after story. We have spent the last decade trying to work with a hospital, our rural hospital. It's a 30-bed hospital. We are not a critical access hospital for a variety of political reasons. Alabama, it's a small, geographically small state. We only have one critical access hospital in the state, so we don't qualify for that type of cost-based reimbursement. There are huge numbers of rural hospitals that are lumped into metropolitan statistical areas like ours. So as Randy well knows, it would be a surprise to every single individual living in this county that we would not be considered rural, but we are considered part of the Birmingham metropolitan statistical area. And if you talk to any of our patients, none of them drive to Birmingham. They can't get there. They'll go to some other small towns, and it's 45 minutes to the easier labor and delivery. In 2015, we opened a labor and delivery. We did it quite uniquely. It's a shared, the hospital handled the infrastructure and half of the staffing. We handled all the physician staffing, anesthesia staffing, and half of the nursing staffing as a part of our community health center. We have written it into our community health center and teaching health center infrastructure as almost as a birthing center, as a maternity unit where some of our community health center nurse practitioners go up and function not really as midwives, but as labor and delivery nurses. And our anesthesiologists help us with colon cancer screening and endoscopy and wound care and central lines, and yes, labor epidurals or C-sections. And so we are hoping that this lecture in 10 years changes the map in rural Alabama, changes our infant mortality rate. We are also, we give every one of our ladies that delivers with us, we give them a crib to take home to try to help the suffocation deaths and the SIDS deaths and impact infant mortality in non-obstetrical ways. Prior to labor and delivery opening, just for context, I've been here since 2003. So there was a 12-year period of time that I had a prenatal care panel, and the patient would drive 45 minutes to the urban hospital, and I had delivery and C-section privileges there. And typically I would have 60 to 70 prenatal patients on the year. I would personally deliver 40 to 45 of them. So in year one, all 60 of our 60 round number prenatal patients stayed. And so we are hoping to grow that number, but at least everybody stayed. So yeah.